Hello everybody, my name is Christoph Zielinski. I'm a professor for medical oncology at the Medical University of Vienna, Austria. I'm very happy to talk for the Hamdan Medical Journal on the topic on recent progress in medicine and the progress in medical oncology. Now, when we concentrate on medical oncology, the new word that really hits everything is personalized medicine. Personalized medicine includes personalization in diagnosis and treatment, and I'll go with you through a couple of examples which show what personalized medicine really means in colorectal cancer, in non-small cell lung cancer, and in breast cancer, which are three very, very important malignancies for their frequency, for the occurrence, and for the options in therapy and treatment we have. Now this, ladies and gentlemen, is a very simplified picture on cancer signaling pathways, showing the very, very many molecular targets which are present once a ligand receptor interaction takes place, and the many mechanisms that occur during the signaling pathway and the signaling cascade, which in the end goes into the nucleus and leads to the proliferation and spread of the tumor cell. Now, we do have, concerning these aspects, predictive biomarkers. The presence of a certain molecular biologic target signifies and shows that there is a prediction possible from the presence of a certain gene. Now, predictive biomarker relates to the effect of a specific treatment, which is important because we then, once the specific molecular target is there, we know which specific treatment will work. It predicts treatment benefit with a positive predictive value, meaning that patients who will respond and benefit do carry this certain molecular biologic structure of this gene, and they have a negative predictive value which predicts that patients who will not benefit from a certain treatment. I will show you a couple of examples. Predictive biomarkers can help physicians select the right treatment for the right patient, because if it's positive, we know which treatment will work. If it's negative, we know which treatment we should not use. And finally, therapeutic intervention can be concentrated on those who will benefit, which leads to the sparing of expense, sparing of resources, and sparing of a series of side effects which might not be truly necessary for certain patients to experience. Now let me give you a couple of examples for these predictive biomarkers in oncology. For breast cancer, it's HER2 overexpression, and there we have trastuzumab and lapatinib. We are having right now, we're experiencing a very impressive broadening of these options with pertuzumab and TDM1, which I will show a little later. CML, which is chronic myelogenous leukemia, the BCR-ABL fusion gene with imatinib, but also others like nilotinib and other compounds which are targeting exactly at this fusion gene. In gastrointestinal stromal tumors, the c-KIT mutation with imatinib, but also with others which are extremely effective in the treatment of this disease, truly showing that the advent of the c-KIT mutation defined a new entity and defined a new treatment option for an hitherto rather unknown entity. Very impressive development. Non-small cell lung cancer, EGFR mutation, gefitinib and alatinib, and metastatic colorectal cancer, the KRAS mutation with panitumumab and cetuximab being negative predictive tumor markers. Now, investigational agents, again for non-small cell lung cancer, were at the time of the slide crizotinib for the ALK and or MET overexpression, right now already in the clinic. And for melanoma, the BRAF mutation with vemurafenib, again already in the clinic for the last couple of months. So we do have very clear-cut options where we see genes, where we see molecular biologic structures, and we do have compounds which can enter the arena for the benefit for the patient. Now, let me discuss with you once again this EGFR cascade, which is truly probably the most important aspect during the last couple of years in solid tumor oncology. Now, we do have EGFR activation, and we do have these EGFR, which is epidermal growth factor receptor ligand structure where we have EGFR being ERB1, ERB2, ERB3, and ERB4. Once there is the ligand receptor interaction, the downstream cascade happens, truly consisting of two big avenues, one being the RAS, RAF, MEK, and ERK pathway, the other being the PI3K, AKT, mTOR pathway, leading again to a proliferation of the tumor cell. So we have these two avenues which are quite important in the transmission of signals. Now, when we look at this in detail, we find that there's this receptor, which is, for instance, in this case, epidermal growth factor receptor. We have a ligand, which is epidermal growth factor, and we do have compounds which block the interaction of this ligand with its receptor, mainly being an antibody. In this context, it was cetuximab, but panitumumab would be another example, both very much in the clinic and both very much used. I will show you this a little later. And these compounds, once you have an interaction of the ligand and the receptor, lead to the activation of these two pathways. You see them here again, PI3K, AKT pathway, or the RAS-RAF, MEK, MAP kinase pathway. And once this happens, you have survival, anti-apoptosis of the tumor cell, invasion, metastases, angiogenesis, chemotherapy and radiotherapy resistance, and proliferation, mutation of the tumor cell. So you see that the signal transduction leads to the proliferation of this entire cell clone. Now, once you inhibit this interaction with the antibody cetuximab or panitumumab, it is supposed that all this here, which is decisive for the spread and the growth of the tumor cells, does not happen. But we do have, of course, very important biomarkers, I would say, predictive markers in the RAS-RAF area, which signify that the antibody does not work, and not only does it not work, but that it's detrimental if you use it. Now let's go back to this, and let's concentrate on this aspect here. Now, mutation in KRAS, which is a part of the RAS molecular biologic structure, mutation in KRAS results in continuous activation of the downstream RAS-MAP kinase pathway, regardless of whether the EGFR is activated or pharmacologically blocked. This means that once you have a mutation within one molecular target, which is KRAS, you have a continuous activation and downstream activation, no matter what you do here or no matter what you do up to the RAS molecular structure. Now, that is very important. That is very important because once you have this KRAS mutation, which happens, you have a continuous growth of the tumor cell. So, what you find out here is once you have this epidermal growth factor receptor, which you can prove by immunohistochemistry, which you can prove by a couple of other mechanisms, once you have the KRAS gene mutation, you are not in the position to really block this appropriately with a drug which would block epidermal growth factor receptor with an antibody. This is being translated in the clinic, and that is very important because once you have KRAS mutations, you are not supposed to give the antibody cetuximab or panitumumab. Now let me show you this. This is a study we did from the Central European Cooperative Oncology Group. It was published in the World Journal of Gastroenterology recently. Cetuximab, which is the anti-EGFR antibody, plus FOLFOX, which is fluorouracil, leucovorin, and oxaliplatin, versus cetuximab plus FOLFIRI, which is fluorouracil, leucovorin, and irinotecan in metastatic colorectal cancer. And this was a randomized phase 2 study where we used cetuximab plus chemotherapy, either consisting of oxaliplatin or irinotecan here. Now, patients received this chemotherapy for up to 6 months, after which cetuximab monotherapy was continued until disease progression or study withdrawal. And what you find here is, now we remember what we said with the KRAS mutation status. we find that with the FOLFOX regimen here, the KRAS wild type patients responded in such a way concerning progression-free survival, whereas the ones who had a KRAS mutant did not respond as well. Not only did they not respond as well, but there was a hazard ratio of 0.49, and this highly significant difference between these two curves, showing that once you had a KRAS mutation, you did not benefit from the addition of cetuximab. This was also true for irinotecan, although a little bit different in this context. Here you have the KRAS mutant, and here you have the KRAS wild type. There you have a crossover, which signifies that there might be a difference concerning irinotecan cetuximab interaction concerning progression-free survival. But nevertheless, this is also true for overall survival, where patients with KRAS wild-type tumors fare significantly better than those who are KRAS mutated, and this concerns both oxaliplatin-based as well as irinotecan-based treatment. Now, so we can say concerning this being a negative predictive marker, you would say that the discovery and development of new markers of cancer should potentially improve cancer screening, diagnosis, and treatment, but cetuximab and panitumumab are indicated for the treatment of patients with wild-type KRAS metastatic colorectal cancer only, should be added here, only. Predicted effects of KRAS status for treatment with EGFR inhibitors like panitumumab or cetuximab in anti-EGFR antibody treatment. The assessment of the KRAS mutation status is obligatory. That is something which is crucial for patients who suffer from metastatic colorectal cancer, because they either have one additional option when KRAS mutation is not present, when KRAS wild type is present, then they do have another treatment option consisting of cetuximab. If KRAS mutation is present, EGFR antibody does not represent another treatment option, leading to the necessity to leave patients either with chemotherapy alone or chemotherapy plus bevacizumab, where there is no such limitation. Now let's turn to the next example, which is non-small cell lung cancer. Here we do have a lot of druggable targets, and we do not have that much of negative predictive, but rather positive predictive biomarkers. Druggable targets like EGFR overexpression, and that would contain EGFR mutation. Then we have MET-ALK mutation, and maybe KRAS mutation. We're getting there. This is not really decided yet. There's still an open question how much KRAS mutation really is important in the clinic. Now let me get back again to the basics and then show you how this is being translated in the clinic. Now when you look at the big chunk of adenocarcinoma non-small cell lung cancer, you will find that within this big entity of non-small cell lung cancer adenocarcinomas, EGFR mutations are present in about 15% of cases, and MET-ALK mutations are present in about 6% of cases, probably around 6% of cases. And you will find this, that you have EGFR activating mutation 10 to 15%, and you would have drugs like erlotinib, gefitinib, and afatinib, which target exactly this EGFR mutation. EGFR mutation means that you are having a constitutive activation of growth, and once you have this present, you have here an option which is better, and I will show you this, better than chemotherapy. So what this leads to is that you can save the patients from unnecessary side effects on one hand, from chemotherapy, and on the other hand, you have something which is much more effective than chemotherapy would be. ALK translocation is a recent development where we do have only 5% of patients, but they respond to crizotinib wonderfully. We had a randomized clinical trial presented at the ESMO conference in Vienna in September, which showed a randomization between docetaxel and crizotinib in the second-line setting of ALK translocated patients, showing that crizotinib fared significantly better than docetaxel in this context. Now, we have another drug which arrived here, which is afatinib, and which complements these three tyrosine kinase inhibitors, gefitinib, erlotinib, and afatinib. Now, mind you, this is very interesting. This is truly very interesting because it shows you a very different biology of diseases. We're all talking, all the time, we're talking about EGFR inhibitors, right? And here we have monoclonal antibodies like panitumumab and cetuximab, which are quite effective once KRAS wild type is present in colorectal cancer, where tyrosine kinase inhibitors by far have no such importance as the antibodies. On the other hand, we have tyrosine kinase inhibitors, gefitinib, alatinib, and afatinib, which are quite important in the treatment of non-small cell lung cancer, adenocarcinoma, once there's a certain mutation, where antibodies are not as effective as these. Sorry. Now, let me show you again this HER family of receptors. Here we have the tyrosine kinase domain of ERB1. Here is EGFR. Here is HER2 with a tyrosine kinase. Here is HER3 without a functioning tyrosine kinase. And here's HER4, which we really do not know yet how to deal with. Now, mind you, there's always this receptor which interacts with a couple of ligands, which you have here, and the tyrosine kinase, which transmits the signal into the tumor cell. Now, HER2 does have a receptor, but no ligand, but it does have a tyrosine kinase. On the other hand, HER3 is a receptor where you do have a ligand called HER-regulin, but no tyrosine kinase, which means that HER2 and HER3 have to heterodimerize in order to take advantage of the ligand which is here and the tyrosine kinase which is there, forming a concept, a new therapeutic concept, which I will come